How is pancreatic cancer resectability determined? Determining the resectability of pancreatic cancer is a complex process that involves several key factors. It starts with a thorough assessment of the tumor's relationship with nearby blood vessels, the characteristics of the tumor itself, and the overall health of the patient. This assessment helps classify pancreatic cancer into 3 categories: resectable, borderline resectable, and locally advanced. Each category guides treatment decisions and helps predict outcomes. The first step in this determination is anatomical evaluation. Doctors use detailed imaging techniques, primarily contrast-enhanced computed tomography scans, to visualize the tumor and its proximity to major blood vessels. Important vessels include the superior mesenteric artery, celiac artery, common hepatic artery, and superior mesenteric vein or portal vein. A tumor is considered resectable if there is no involvement of the arteries and only minimal venous involvement that can be safely reconstructed during surgery. In contrast, borderline resectable tumors may show limited encasement or abutment of these vessels, making surgical removal more challenging but still potentially feasible with vascular reconstruction. Locally advanced tumors, however, exhibit extensive arterial encasement or unreconstructible venous involvement, which typically rules out surgery. Next, biological factors play a significant role in determining resectability. Tumor markers, such as Ca19-9, are crucial indicators. Elevated levels of Ca19-9, particularly those above 500 units per milliliter, may suggest a more aggressive disease and a poorer prognosis. These biological markers help identify cases that are biologically borderline resectable, where surgery might not be beneficial even if the anatomy appears favorable. Additionally, patient-related factors are essential in the decision-making process. A patient's overall health, existing medical conditions, and ability to tolerate major surgery are critical considerations. This aspect, known as conditional resectability, ensures that only patients who can safely undergo the complex operation and recovery are considered for surgery. The determination of resectability is not made in isolation. It involves a multidisciplinary team of specialists, including surgeons, radiologists, and oncologists. They utilize standardized criteria from organizations like the National Comprehensive Cancer Network or newer guidelines, such as the Rediscover recommendations. These guidelines integrate anatomical, biological, and conditional factors into a comprehensive assessment known as the A, B, and C criteria. In some cases, especially with borderline and locally advanced tumors, neoadjuvant therapy may be employed. This involves administering chemotherapy and/or radiation before surgery to shrink the tumor, potentially improving resectability. After treatment, further imaging and clinical assessments help determine if surgery is now feasible. In summary, the determination of pancreatic cancer resectability hinges on a combination of anatomical relationships with blood vessels, biological aggressiveness indicated by tumor markers, and the patient's overall health. This integrated approach helps ensure that only those patients who are likely to benefit from surgery proceed with resection, ultimately optimizing outcomes in the management of pancreatic cancer. Always consult healthcare professionals for personalized medical advice and treatment options.